Welcome to this explainer on Dr. Abdulgnee Quitina's presentation covering cardiac arrest and resuscitation. Today, we're unpacking the brand new 2025 American Heart Association guidelines, and we're going to look at this strictly through the lens of emergency medicine essentials. You know, this isn't just some dusty medical protocol. It's the ultimate high-stakes race against time where literally every single second counts. When a patient codes, that clock starts, and a highly coordinated dance of mechanics, pharmacology, and human teamwork has to happen instantly. Okay, let's dive right into this, because we really need to clear up what a cardiac crisis actually looks like. If you watch Hollywood movies, someone collapses, a doctor dramatically yells clear, shocks a flatline once, and suddenly the patient wakes up and starts talking. Right? Well, the physiological reality of an emergency is far messier, way more complex, and honestly, infinitely more fascinating. It requires immense discipline and a very specific sequence of actions to literally bring a human body back from the brink. And it all starts right here. 10 seconds. That is the absolute maximum amount of time a responder has to confirm cardiac arrest. You have less than 10 seconds to check for unresponsiveness, to look for abnormal gasping, those agonal breaths, and to feel for an absent carotid or femoral pulse. If those signs are there, the emergency response system must be activated immediately. There's just no time for hesitation. So here is our roadmap for today. First, recognizing the crisis, then basic life support, navigating the two rhythms, advanced interventions, and finally, team dynamics.
Section 1. Recognizing the cardiac crisis. Identifying the ultimate physiological emergency.
Before a team can even try to fix the problem, they have to understand the exact physiological catastrophe that's unfolding right in front of them. Cardiac arrest is defined as the sudden cessation of cardiac output, and with that, the complete cessation of oxygen delivery throughout the body. I really want to stress this. This is the ultimate life-threatening emergency. Without oxygen, vital organs, especially the brain, they start dying in minutes. The body's engine has completely stopped, and it is entirely on the responders to manually pump the fuel.
And this brilliantly illustrates how responders fight back, using the 2025 AHA Chain of Survival. It's a series of integrated steps designed to maximize the chance of survival. It builds this forward momentum from the initial collapse, activating the emergency response, through high-quality CPR and early defibrillation, right into advanced resuscitation, post-cardiac arrest care, and ultimately recovery. If any single link in this chain breaks, well, the patient's chances just plummet.
Section 2. Foundation. Basic life support. The mechanical bedrock of survival.
Before the advanced drugs and the specialized equipment even arrive, we need immediate physical action to literally buy the patient time. So, the crucial point is the CAB approach: compressions, airway, breathing. The 2025 AHA algorithm places massive emphasis on this. Notice the compressions come first. Prompt recognition and getting right on that chest is the absolute foundation of high-quality basic life support.
And those compressions, they must be high quality. That means pushing hard and pushing fast. The target is a steady, urgent rhythm of 100 to 120 compressions per minute. You got to push at least 2 inches deep, or 5 centimeters, to manually squeeze that heart, and then allow for complete chest recoil so it can refill with blood. And critically, you must minimize interruptions. You want any pause in compressions to be well under 10 seconds.
Section 3. Navigating the two rhythms. The critical fork in the treatment road. So, what happens when basic CPR just isn't enough?
Well, this is where we need to correct a huge public misconception. You do not shock every cardiac arrest. There are two distinct categories here. First, we have shockable rhythms, ventricular fibrillation, and pulseless ventricular tachycardia. The heart is quivering chaotically, and the shock can actually reset it. But second, we have non-shockable rhythms, asystole, the famous flatline, and pulseless electrical activity, or PEA. For these, a shock will not help. Defibrillation is not indicated. Instead, you rely entirely on high-quality CPR and medication.
Let's look at the exact sequence for a shockable rhythm. The probability of successful defibrillation drops rapidly over time, so early action is absolutely key. For a witnessed arrest with a shockable rhythm, it's an immediate shock at minute 0. Then, 2 full minutes of CPR. At minute 4, a second shock, followed by more CPR and a dose of epinephrine. If the rhythm is still shockable at minute 8, a third shock is delivered, followed by an antiarrhythmic drug like amiodarone. It is a relentless, fast-paced cycle. Now, what's really interesting about this 2025 update is the inclusion of double sequential defibrillation, or DSD. If a patient is in a stubborn, refractory shockable rhythm, meaning standard shocks and amiodarone have failed, teams with specific equipment and training can actually use 2 defibrillators to deliver sequential shocks. It's a highly aggressive, innovative strategy for the hardest-to-treat electrical storms in the heart.
Section 4. Advanced Interventions and Causes. Medications, Diagnostics, and Special Circumstances.
As we move deeper into the algorithm, high-tech tools and complex medical decision-making come into play. Systematically, the pharmacology is incredibly precise. Epinephrine is your heavy hitter, a Class 1 recommendation, given as a 1 mg dose every 3 to 5 minutes for both shockable and non-shockable rhythms. If a patient is in a refractory shockable rhythm, antiarrhythmics like amiodarone, usually 300 mg, then 150, or lidocaine at 1 to 1.5 mg per kilogram are introduced to try and stabilize the electrical activity. Oh, and there's also magnesium, but that's specifically reserved for a unique type of polymorphic ventricular tachycardia called torsades points.
But just pushing drugs isn't enough. The medical team has to act like detectives right in the middle of this chaos. They have to continuously diagnose and treat the reversible causes of the arrest, which we call the H's and T's. Like, is the patient hypovolemic from blood loss? Are they hypoxic? Is there a tension pneumothorax or a massive pulmonary thrombosis? Because if the team doesn't identify and reverse that underlying cause, no amount of CPR or epinephrine is going to permanently restart that heart. The 2025 guidelines also give us tailored protocols for special circumstances, like poisoning, pregnancy, or drowning. Plus, they highlight some really incredible advanced tools. For instance, extracorporeal CPR, or eCPR, uses an ECMO machine to totally bypass the heart and lungs, and that's showing a 20 to 45% survival rate for refractory in-hospital arrests. And capnography, measuring exhaled carbon dioxide, is used to confirm advanced airway placement and monitor the actual quality of the CPR being delivered.
Section 5. Team Dynamics and Outcomes. The human element of resuscitation.
Okay, so we've talked about the algorithms and the hard science, but how is this incredibly chaotic protocol actually executed by real people under immense pressure? Well, the answer is pit crew CPR. High-performance resuscitation requires a fiercely coordinated team where everyone has a hyper-specific role. You've got a team leader overseeing the big picture, dedicated compressors rotating out to stay fresh, an airway manager, someone on IV access and meds, a defibrillator operator, and a timekeeper. They use closed-loop communication, meaning the leader gives an order and the team member verbally confirms when the task is complete. It literally turns potential chaos into a mechanical, life-saving precision.
But despite perfect execution, not every patient can be saved. The 2025 AHA guidelines offer refined rules to help emergency professionals navigate the really heavy ethical decisions of when to terminate resuscitation. Team leaders have to weigh factors like the time since the arrest, whether it was witnessed, the initial rhythm, whether any pulse was temporarily achieved, and crucially, the patient's pre-existing conditions and advanced directives. It is a massive, massive burden to carry.
Which leaves us with a profound final thought. We have these amazing algorithms, life-saving drugs, and incredible technology like eCPR. But when the medical science reaches its absolute limit, how does a team carry the ethical weight of making that final call? Resuscitation is a triumph of modern medicine, for sure, but it relies entirely on the skill, the speed, and the incredible judgment of the humans running the code. Thanks for joining me on this explainer of the 2025 AHA guidelines. So what will you take away from all this for the next time? Every second counts.
Thank you for watching this edition of the Emergency Medicine series. If you found this session valuable, please click the subscribe button below and turn on notifications to never miss an episode. Stay safe, keep learning, and I'll see you in the next lecture.